Alright guys, let's get busy talking about breast cancer. Let's start out by talking about the pathophysiology. It's going to be really similar to our other cancers. It's going to be neoplastic transformation, but this time the tissue in question is going to be our breast tissue. However, we need to know two important types of breast tissue on exam day, and that is going to be our ductal tissue and also our lobular tissue. So let's go ahead and take a closer look at this in our anatomical diagram. We'll start out with our ductal tissue. So our ductal tissue, I'm going to highlight here in blue, and you can see it's out here towards the tip of the nipple, and this is the tissue that is responsible for expressing milk out to the baby. And then behind that we have our lobular tissue, which I'm highlighting here in green, and this is going to be the tissue that is responsible for creating milk. So these are the milk producing lobules, and the ducts are where the milk that has been created goes out towards the baby. So let's talk about some risk factors and background when it comes to breast cancer, because these are things that test writers love to ask on test day. So let's start out by talking about increased incidence with increased age. And this makes sense. This is a general rule that applies to most of our cancers. The longer that you live here on Earth, the more time you have to be exposed to things like radiation or chemical exposures and just cell breakdown and damage. And this can lead to increased risks of cancer, including breast cancer. Additionally, having a family history is going to be an important factor in your risk of developing breast cancer. There are two specific groups that are important on test day, and this is going to be that white patients are more common in getting breast cancer overall, and then our black patients are more common to get something called triple negative breast cancer. And I want you guys to hold on to this idea of a triple negative breast cancer because it's referring to being negative for certain breast cancer receptors. We're going to talk about this a little later on, so hold on to that in your mind and we'll revisit that. Additionally, let's talk about BRCA1 and 2 mutations. So BRCA is going to be a big hitter on test day, and this is because it is a special tumor suppressor gene. So it's a tumor suppressor gene, and it's also referred to as a caretaker gene. And the reason why it's a caretaker is because it's responsible for DNA repair. However, we can get mutations in BRCA. These are usually autosomal dominant mutations, and this is going to be important on test day. They like to ask about the inheritance pattern. Another risk factor to know on test day is going to be increased estrogen exposure. We know that breast tissue is estrogen sensitive, and therefore increased levels of estrogen are going to lead you to increased levels of cancer. Now, some periods of time in our life where we have increased estrogen exposure are going to be when we are not pregnant. So women who never got pregnant or who never breastfed, during those periods of their lives, they were exposed to more estrogen than women who were pregnant or who were breastfeeding, because during those periods of time, those people tend to have less levels of estrogen because pregnancy, we know, is largely dominated by progesterone, and when we're breastfeeding, our menstrual cycle stops, so we are not producing those big surges in estrogen. So having babies or breastfeeding are protective factors against breast cancer. Additionally, having early periods or late menopause are risk factors, because if you start menstruating early, your estrogen burden goes up much earlier in life, and if you menstruate later on in your life, your estrogen burden is continuing later than other women who may have stopped menstruating earlier. Lastly, let's talk about alcohol use. This is going to be a risk factor for a lot of cancers, and breast cancer here is included. And then we can also have breast cancer in our male patients, and the things that test writers like to ask about is that Klinefelter's puts you at an increased risk, and also BRCA2 mutations. And we talked about how BRCA works, how it codes for a tumor suppressing caretaker protein, and so that's going to be an important thing in terms of our male patients for BRCA2 specifically. Lastly, let's talk about our prognosis, and this is going to be guided by our biopsies. So we're going to get biopsies of our tumor and also biopsies of the lymph nodes surrounding the tumor, and this is where we look for the receptors. So I was talking about triple negative breast cancer earlier, and so we have specific receptors on our breast cancer tissue, and these are going to tell us how receptive breast cancer is to certain treatments or the prognostic values. And this is why triple negative breast cancer in black patients is usually a really sad diagnosis to hear, because this is an exceptionally aggressive type of cancer. So let's talk a little bit about some of our receptors. So what we have here is overexpression of estrogen and progesterone receptors. Some specific ones that we need to know on test day are going to be CERB2, HER2, and EGF. And it's important to know that triple negative is going to be the most aggressive type of breast cancer. This is going to be more common in our black patients. Lastly, let's talk a little bit about our presentation. This is going to be a general rule for breast cancers. We're going to go over some tables that have more specifics later on in a bit, but I wanted to give you guys some general rules. So the presentation is going to be variable, but usually we're going to have some type of mass. This is usually characteristic, but it doesn't always have to be there. Additionally, we can see types of nipple discharge. Usually blood-tinged nipple discharge is going to be leading you down the breast cancer route, as opposed to, let's say, milk that's coming out of the nipple. That could be something like a prolactinoma or a drug that is causing galactorrhea. Additionally, breast ulcerations, edema of the arm, or lymphadenopathy, especially in the axilla. This is where the drainage of the breast tissue goes, is going to be characteristic of breast cancer. And then our invasive tumors are going to cause some more significant findings. So our invasive tumors are going to involve the pectoral muscles and Cooper's ligaments. And let's take a look at that anatomy. So if we look at our pectoral muscles here, it's these muscles here that we're viewing in our sagittal plane, and then our Cooper's ligaments are going to be ligaments that support the breast. So you can imagine that if you had a big tumor here, which I'm denoting with this star, it's going to have a real estate effect where it's going to be pushing on these muscles, pulling on ligaments, and this can cause the skin to dimple or the nipple to invert because it's changing the architecture of our breast tissue. And so this is going to be something to be on the lookout on test day. And then finally, I just want to highlight for you guys the skin dimpling and the nipple retraction and inversion. We're going to talk about all the specifics of our specific tumors and how they present in the tables to come, so stay tuned for that.